Welcome to ICU Primary Prepcast. This is another primary snippet for this week, and I'm joined by Dr. Mike Clifford again from Melbourne. Welcome, Mike.
Thank you, Swapnil. Hello again.
Last time we discussed about West Zone, so this week we are going to discuss about airway resistance. So can you please explain what are the physiological factors that affect airway resistance?
Okay, excellent. So this is another fairly common SAQ and often repeated. It's relatively straightforward. It's nice core material. There's two key words in this request. One is physiological factors. So by definition, you don't have to talk about any pathology. And then airway resistance, we're purely talking about the resistive element of the airway, right? So we don't have to worry about tissue or lung inertia or any of that sort of stuff. We're just looking at the flow of gas in the airway. So as can be expected, airway resistance is the frictional resistance to gas flow in the airway, and it's equal to the driving pressure divided by the flow, okay? And normal airway resistance is fairly low. It's about 2 centimetres of water per litre per second, and that's largely due to resistance in the medium-sized bronchi. There's a lovely graph that shows how resistance changes over the airway, and it starts moderately high, then goes up, peaks, and then drops all the way down as you go down through your increased orders of branching in the airway. So paradoxically, despite the fact you've got these tiny little tubes you're breathing through, because you've got so many millions of them, it's actually very easy to breathe through them. So your peak resistance is actually occurring up in your higher order branching. Now, that's true in the adult. If you have a look at infants, their resistance peaks in the nasopharynx, okay? And that's one of the reasons why they have such an increased effort of breathing, is because they're breathing through their nostrils, and that's their highest area of resistance. But to all intents and purposes for the exam, your resistance peaks in your upper branches and then it drops away quite quickly. And the resistance will depend, as it does in any tube, on whether the flow is laminar or turbulent. And the resistance is significantly less when flow is laminar, okay? So how do we calculate that? Well, we rely on Hagen-Poiseuille's equation when we're talking about laminar flow, and that's the R equals 8 NL over pi R4 on the viscosity. So you've got N equals viscosity, L equals length, R equals radius. And whether flow is turbulent or not will be predicted by Reynolds number. And Reynolds number is the function that relates gas density to tubular diameter and relates that to the velocity divided by the viscosity. So you've got density multiplied by diameter multiplied by velocity divided by viscosity. And the numbers to remember are 2,000 and 4,000. If your Reynolds number is less than 2,000, you'll have laminar flow. If your number is over 4,000, you'll have turbulent flow. And the reality is, in the human airway, it's almost always a mixture and mostly turbulent, because it takes quite a while for flow down a tube to reach the point where it has laminar flow. So effectively in humans, it's not until your 11th branching. So that's quite well down the lung. So to all intents and purposes, all the gas flow in your nose and your trachea and your bronchi and your major bronchi and your middle order bronchi, all of that stuff, you've got effectively turbulent flow. You don't get laminar flow till you're all the way down into the bronchioles and just before the respiratory bronchioles, down at sort of the 11th generation, because you need quite a long piece of pipe before turbulent flow has a chance to become laminar. And many of our respiratory pipes are quite short, and the branches are coming off at various angles. So it's actually quite a difficult trick for us to get laminar flow in our respiratory system. But the important thing for your written answer is that you write that there is turbulent flow and laminar flow. Laminar flow, you've got the Hagen-Poiseuille equation. The Reynolds number will predict what you've got, and that you do get laminar flow in those much lower branches, okay? You can then answer your question about the physiological factors of influence. That will be those that influence airway diameter. And the things that affect airway diameter are obviously lung volume. So resistance is an inverse function of lung volume. As you increase your lung volume, you increase the radial traction on all of your airways and all of your pipes. So those pipes get larger, and that has a significant effect on resistance. Obviously, when you're breathing in, you're tending to open up all those tubes, and when you're breathing out, you're tending to compress them. So your airways resistance increases during expiration. And you can even end up with lung closure. So you get even further reductions in lung opening and increasing airways resistance. The position of your lung in space, so in the supine position, breathing at volumes close to closing capacity will increase your airways resistance. And then things that can tend to narrow or compress your airway, that's largely the balance between your sympathetic and your parasympathetic nervous system. So the sympathetic tone on your bronchial smooth muscles causes bronchodilation and tends to open up those airways that have smooth muscle in the wall. And similarly, parasympathetic activation tends to cause local constriction of those airways and reduced diameter and increased airways resistance. Things like foreign bodies, mucus plugging, and disease are not physiological factors. So I wouldn't rush to put them in your answer unless you've written all of the other factors and you're down at the bottom, because you theoretically, in this question, you shouldn't necessarily score marks for writing pathological changes. But things like local cellular mechanisms, cytokine reactions and changes, the role of nitric oxide they're all on that balance between what is physiology and what is pathophysiology. And there's no perfect answer to that. But if they're the last bit of your answer rather than the first bit of your answer, that's important. So the big things to talk about are, airway size, airway opening, airway conductance, then talk about airway diameter down to the 11th order of branching. And then after that, the effects of parasympathetic and sympathetic nervous system on modulating the diameter of those airways as the chief factors. It's important to remember that things like airway density and viscosity don't really come into it because we're not normally breathing anything other than air or oxygen. And the differences between those two in terms of their viscosity or density is fairly minimal and doesn't affect resistance to any great degree. And this isn't a question of pharmacology, so we're not talking about helium. So you can park that and not worry about it and just focus on the effects of airway diameter as the chief problem.
Thanks, Mike. It's often quite tempting for candidates to answer a lot of pathological factors affecting airway resistance, and that's a common mistake. They will talk about the drugs that cause bronchoconstrictions, the pathologies like COPD, asthma causing bronchoconstriction, and that's not really the focus of this question. The focus is simply what are the physiological factors in normal, healthy adult patient that affect the airway resistance.
Yeah, I mean, and it's very tricky because almost all of our patients that come into ICU are on some drug, and particularly if they've got a respiratory problem, they'll be on drugs that will be affecting their airways, and many of the drugs we use will affect those things. But I think if you take a step back and say, how can I link anything physiologically, it's all about what those drugs do to the sympathetic and the parasympathetic nervous system. If the drugs don't have direct effect on the receptors of those systems, then the fact that propofol reduces your sympathetic nervous system and lets your airways relax, I mean, that you're pushing to get a link. So if a question says what are the physiological effects, try and stay very true to that question, and you'll get more marks than if you go off piste and start describing pathology and pathophysiology and then pathopharmacology, because you're not going to be scoring marks doing that. So try and maintain core physiological descriptions in the body of your answer.
That's correct. So thanks, Mike. Thanks for explaining this quite nicely. So that's the end of our today's snippet. We'll be back with another snippet in a week's time. Till then, goodbye and have a nice day.
Okay, see you later. Thanks, Swapnil.